I'm Alicia Carrasco. I am internal medicine, addiction medicine, and work in our pain clinic at the VA. So kind of as an addiction, pain, substance use person. And the talk I'm going to give the caveat, I am giving this talk from a hotel room and I don't have access to my little notes. So I may be a little bit scattered because I usually rely on those notes. So I apologize ahead of time, but we'll do the best we can together. So if you can go to the next slide. What I hope that we can get out of this talk today is, one, identify patients that are good, potential candidates for long-acting injectable buprenorphine, that you can counsel them on the pros and cons of injectable buprenorphine, and then be able to at least know some basic differences between Brixadi and Sublocade, which are the two FDA-approved long-acting injectable buprenorphine formulations. All right, we can go to the next slide. So this is not going to be a talk on buprenorphine in general. I'm not going to talk about the pharmacology, why we use it, etc. But I do think it's helpful to do a quick review of the options that are currently readily available for folks. So the cheapest is Subutex, and Subutex is a tab that dissolves underneath the tongue, and it is just buprenorphine. There is no naloxone component. Slightly more expensive is the buprenorphine naloxone combo pill. And so this has naloxone, which is not very bioavailable. So it's not really active in the blood, but it is meant as an abuse deterrent. So patients can't inject it. And this is slightly more expensive than the Subutex, but still relatively inexpensive in the world of meds. A step up, even more expensive and usually better tolerated, are the films, which don't taste quite as bad. I have the most experience with Suboxone, so that's why I have a picture of it, but there are other ones like Subzolve, and there's another brand out there, and they're all pretty much bioequivalent. And this is what we have for most of our patients, most places where buprenorphine is available. But it's not always enough, and so it's exciting to know that we have a new option or two new options out there, and we can go to the next slide. So those are the Brixadi and the Sublocade, and those are the brand names of the long-acting injectable buprenorphine formulations that are available. Both are, it's a really cool pharmacology, and as I was giving this, preparing for this talk, I was like, I am not a pharmacist, so maybe Kathy could help us out here with some of how these things work. But it is a liquid when it goes into the body, and then the second that it makes contact with body fluids, it solidifies somewhat. So it is a subcutaneous injection that solidifies and forms this crystalline matrix once it gets inside the body. And it is more expensive if you are paying for it yourself, but for our patients who have Medicaid, for our patients that have VA insurance, for example, it's going to be, it's open formulary. So for them, there's not actually a huge cost barrier for this. You can imagine this is buprenorphine. So you're going to have the same exact risk profile as you would with any buprenorphine formulation, with a couple notable exceptions. One is we are bypassing the mouth, right? And so we think that we are probably going to see fewer dental complications with the injectable formulations. So if you remember, if those of you who do buprenorphine a lot, there's a warning on there. I don't know if it's a black box warning or something less dramatic, but that's this can cause dental caries. Be careful with it. We don't think we're going to see very much with that when we're bypassing the mouth and using the injections. But we will see some more cutaneous side effects and manifestations. So if this injection is done incorrectly, that crystalline matrix, instead of forming underneath the skin, forms within the skin, and you could potentially get tissue necrosis. And if someone injects it into the muscle, you can have complications there too. Okay, and you can go to the next one. So who would we consider for these medications? One, if you're concerned for diversion, right? Maybe you have proof, maybe you don't, but you're just not sure that those meds are all going to where you want them to go. But you know that they're taking enough that you feel like this is safe. That would be a great patient to consider transitioning. The biggest one in my mind is the intermittent treatment adherence. And I see this for two big reasons. One, I have some patients that just do not have the executive function to be able to make an appointment and get to that appointment before they run out of meds, right? Like whether it's because they can't get out of the house on time, because they just don't know they're out of meds until it's already been 2 days and they're in withdrawal, whatever it is. Some patients just really struggle with executive function and keeping on top of appointments. The other large group where I see this is patients that maybe they have a well-controlled opioid use disorder, but they have a poorly controlled stimulant use disorder. And so they might go use meth for a week or two. And when they're using meth, then they forget to take their buprenorphine. And so then I have this up and down of opioid blockade, which gives me severe anxiety for many reasons as a provider, right? So like one, when they're not taking their buprenorphine, they're going to have cravings that are more likely to return to use. And secondly, if someone, let's say they use meth on day one and they have buprenorphine on board, and that meth has some fentanyl in there, the buprenorphine is going to protect them from that fentanyl, so they're not going to overdose. And if they forget to take their buprenorphine for a couple of days and use that exact same amount of meth with the fentanyl in there, then they can overdose and die. Right. So there's a lot of safety concerns with like variable buprenorphine levels. And so if there's someone who has intermittent treatment adherence, regardless of the reason for it, they are a great candidate for long-acting injectable buprenorphine. Justice involvement, I think, is a great place. And I saw there was someone here who works in like the Justice Department. So I was very excited. I hope that we see this more in the future. We don't see enough, in my opinion, treatment for opioid use disorder when people are incarcerated. And some of that is logistically, you can imagine it's quite difficult to give someone a controlled substance in an incarceral setting where you have to like watch and wait for it to dissolve. And there's street value and all of that. So it's logistically difficult to treat people with the transmucosal dosing. However, if you can just do a monthly dose, it really diminishes that activation energy and the safety concerns associated with that, and also can provide protection in that immediate period post-release, which is one of the riskiest periods in terms of accidental overdose mortality. Where I see it a lot too with justice involved folks are folks in drug court. So for example, our prosecutor for vets court in Ada County did not like people being on buprenorphine and driving because he was concerned that, well, I don't know how much buprenorphine they're taking. I don't know if they're taking it the way that they should be taking it. And so I don't feel safe having folks on the road if they're on buprenorphine. And you can imagine it's really hard to live in Idaho and go to your drug court appointment every single day if you can't drive. So he was able to say, okay, if they're on Sublocade, then we will allow it because there's a more steady dose and I can kind of be more confident that they're not overtaking it. So that was, frankly, the largest population that I had on Sublocade for quite a long time were patients that were in Veterans Court. Patients with medication storage concerns. So we'll see this a lot in our patients that are unhoused. Buprenorphine is less addictive and has lower street value than other opioids, but still has street value and gets stolen all the time. So patients that do not have a safe place to store their medications, if we can get them an injection so they are storing it in their body as opposed to on their person, that helps a lot. Or patients with a lot of kids in the house, or maybe someone else in the house that also has an opioid use disorder and can access their meds. These are patients where it's really better to store that medication internally, subcutaneously, than it is to store it in a bottle. I have the next one on the bottom. It should be at the top. Patient preference, right? If a patient just wants it, right? They're like, I just don't like taking meds. I don't like thinking about it. I would rather have a once a month injection. Then I'm like, great. Here's the number to our nurse, like call your appointment. Let's get you started. And I put the last one with a question mark because I don't have any trials to back it up, but we do think that there are significantly fewer dental concerns associated with the injectable Brixadi and Sublocade. So patients whose teeth are just not in a good place, if I'm able to transition them, I might transition them just to kind of not add more problems to the mouth area. Okay. People that you would not want to place on Sublocade. One, if you are allergic to any of the components of the injection. And It is a soy-based crystalline matrix. I do not see that a soy allergy is an absolute contraindication, so maybe Kathy later can weigh in on that. But obviously, if you had an injection before and had an allergic reaction, don't do the second one. This is a soft contraindication, but if you have a major upcoming surgery, that might not be the best time to blockade most of the opioid receptors. So if someone's going to have like a major back surgery or something, it doesn't mean you can't. You can still treat pain on top of it with even opioids, but it's going to be a lot higher doses and a lot harder to control that pain. And people are just going to panic, like surgeons and anesthesia are not going to be happy with you. Be careful with moderate to severe hepatic impairment. So child's B or C cirrhosis, we want to be more careful. It doesn't mean you can't use it, but you got to be careful about it. And if there's any integrity issues of the skin at the site where you would be injecting, like there's a skin infection or a ton of scar tissue that's going to affect absorption, then those aren't patients that you probably want to start on these options right now. Okay, we can skip to the next slide. So the first option, this is the one that it's newer and shinier, so I'm starting with this one, and this is the Brixadi, and it comes in two big formulations. So it comes in weekly dosing and in monthly dosing, and within the weekly dosing, there's an array of options, and within the monthly dosing, there's an array of options. For the weekly dose, all you have to do is one single one-time dose of 4 milligrams of buprenorphine, and if they tolerate that and they're not having precipitated withdrawal and they're not falling asleep, then you can go ahead and get them started on a weekly injection of Brixadi. For the month-long injections, we generally want them to be on a stable dose, so about 5 to 7 days on a dose before you start the injections. And we have a lot of options on where to inject. So you can see the picture here is from the package insert, and it will show you the different options of places that you can inject. And I did some really fancy artwork, and I made the arms yellow for you. And that's because if you inject in the arms, there's about 10% less systemic absorption than if you inject in the other places. So you can inject there, but we generally don't recommend that you do that unless they're already at a steady state, and the difference of 10% is not that big of a deal. Now, the needle is pictured there. It's like a very dramatic thing that comes preloaded for you, and it's a 23 gauge syringe, so it's a pretty small needle, and the volume, depending on the dose that you're giving, is 0.16 mils to 0.64 mils, so a pretty small volume. And it does form some sort of crystalline matrix when it hits your body, but it's not so extreme that you can like cut it out and remove the blob, right? It's just kind of like crystalline underneath the skin, and sometimes you might not even feel it. So those are kind of like the key points with the Brixadi, and we'll talk more about dosing later. Now Sublocade, we can go to I was trying to advance them myself and failing. Not good at this. Okay. Sublocade, you don't have as many options of where you inject, so it needs to be in this transpyloric plane, so plane. So basically around the belly button, and you just go in a circle over and over. This one, you do want the patient to be on a stable dose in theory before you start. So you ideally want them on a stable dose for 7 days of between 8 and 24 milligrams of buprenorphine before you start the Sublocade injection. And it is a hefty needle. So it is an 18 gauge needle. For the booster dose, for most people, the starting dose is 300 milligrams, which is 1.5 mils of fluid and viscous fluid that forms a solid. And then if the 100 milligrams, then it's slightly less, it's 0.5. And this one does actually firm up enough when it hits the body that you can actually physically go in, cut the skin, and pull it out for the first 2 weeks after you give the injections. So there is this option for surgical removal. And this one, I don't have as much experience with the Brixadi, but I will say my patients say that it hurts quite a bit to get the Sublocade injections, and that makes sense. It is a viscous fluid, it is going subcutaneous, and it is forming a solid. So it is quite uncomfortable to get the injection, and there are ways that you can work around that. We give Emla cream just to kind of numb the skin a little bit ahead of time. You can have patients use ice to help with that. It is off-label, so the company does not recommend it, but you can do an injection of lidocaine in the area to numb it up and then take it. The reason the company doesn't recommend it is because they didn't study it that way, so they don't know if a lidocaine injection is going to affect the absorption rate of the buprenorphine that's in there. So it can be really painful. I will say there's this, I say here that you should be on a stable dose for 7 days. There's some really interesting studies coming out of, especially the emergency room literature, that are talking about cold starts for Sublocade. So patients that are presenting to the emergency room in withdrawal and starting them directly on Sublocade without stabilizing them on sublingual buprenorphine, and that a lot of those patients actually seem to do really well. So I have not personally done that, but it is something that people are doing. All right, so in terms of starting, you can go to the next slide. Sublocade's a little bit different from the Brixadi because we start everyone at 300 milligrams and then kind of go down on subsequent dosing. So this table I made myself from the package inserts. And so the package inserts of the sublingual buprenorphine comparisons are slightly different between the two. So this is not 100% the same as what you will find in both of them, but it's very, very similar. So for patients on less than 6 milligrams, your only option is a weekly 8 milligram Brixadi. If they're on, say, 10 milligrams of sublingual buprenorphine, then we can get them on 64 milligrams of Brixadi, or you can do Sublocade 300 milligrams for that first dose. The second dose is 100. The third dose is 100. 16 milligrams, you can do 96 of Brixadi, or you can start them at 300 of Sublocade. The next month, if they're doing okay, you go down to 100 and then keep them on 100 thereafter. That second month, if they're still having cravings or they have had return to use, then you would continue them on 300 for an additional month before going down. If they're on 24 milligrams, then you can do 128 of Brixadi or Sublocade 300, then 300, then going down to 100. And patients that are on higher doses, so like 32 milligrams of buprenorphine, or patients that maybe they're only on 24 milligrams, but they're still really struggling with cravings and use, those are patients that I think you should preferentially do Sublocade because we can achieve higher serum levels with Sublocade if we keep them at 300. And that's what the next slide shows, I think. We'll see. Drum roll. Okay, good. That is what the next slide shows. So you can see the gray line, the third from the bottom, is the serum levels of the transmucosal or the sublingual buprenorphine. And so all the way on the left is trough. In the middle is the max serum concentration. And then on the right is the average serum concentration. So this is not this graph I made myself from the package, the data in the package insert. This is not over time, right? So this is not representing how much time people spend at each level. This is just a visual representation of what their trough is, what their max is, and what their average is. And I want you to really focus on the right side. This is their average concentration. So this is where they are going to be spending most of their time. And you can see the third from the bottom is the person's average buprenorphine concentration when they are on 24 milligrams, so a pretty hefty dose of sublingual buprenorphine. And above that is the steady state for the 100 milligram injectable buprenorphine of Sublocade. Above that is the Brixadi 128 milligram steady state dose. And then way above that is the steady state that we're going to achieve if we keep someone on a 300 milligram dose of Sublocade. So we can really achieve significantly higher serum levels of buprenorphine with the Sublocade than we can with the Brixadi. But even the Brixadi gives us higher serum levels, like the higher dose of the Brixadi gives us higher serum levels than we can achieve with the traditional upper limit of buprenorphine dosing with the transmucosal stuff. Okay, so you can go to the next slide. This is, now these medications are awesome, right? Like they can be really helpful. They can also, you can imagine, be very not helpful / expedite death if you were to give it in a vein, say. And so because of that, they are under, they are a REMS medication, which means that the government or the company has specific oversight in terms of who can give the medication, just to make sure that people know how to do the injections correctly and that they know how to store it correctly and safely. So for prescribers, if you're a prescriber on here, you can just prescribe it. You can just prescribe it to like a specialized pharmacy. You don't need to do anything special. You don't need a special anything. And if your clinic is not licensed to give them, you don't have REMS certification, that's okay. If you call the specialized pharmacy and you say, hey, I have this patient, this is their date of birth, this is the day that they're coming in, and this is the time of their appointment, the company, that pharmacy, will physically deliver the medication to you so that you can give it to the patient. But there has to be like a controlled chain of custody, which means that the patient can't ever physically have this medication themselves. It has to stay with like a medical provider, or like a certified person who is not the medication. So if you just have one patient that you want on this, I think that's a fine option. If you are a facility that is doing more treatment with injectable buprenorphine, I think it makes sense to get REMS certified. And I don't think that complicated. And I say that hesitating because I've never done it, but I have talked to our pharmacist who did it, and she said it's actually not that hard. And you can go to the next slide, Jocelyn. So there is, if you go, you can use this QR code. You can also just Google it, like REMS certification Brixadi or REMS certification Sublocade, and it'll tell you how to get your site set up for dispensing it and giving it. And so, there's certain things you have to be able to keep it in a refrigerator. You have to keep it locked up so that people aren't having access to it. And then, I think the trickiest thing is that you have to figure out what you're going to stock, right? And it's in a pretty expensive med. And so you have to coordinate with the DEA to figure out how many patients you think are going to be getting the injection that month, and then make sure that you have the appropriate amount of medications in stock. So I think it's a pretty exciting option for our patients, where we were traditionally having to send our unstable patients to do daily dosing of methadone, which, one, is not a great option for all of our patients. Two, is just logistically really difficult to get to any place every day. Three, that's not even available in a lot of Idaho, right? We are lucky in Boise that we have places, but a lot of Idaho doesn't. So it's really opened up the treatment possibilities for a lot of our patients, which I think is really exciting. So in summary, I think I'm on my summary slide. We'll find out. Jocelyn, let's see. Yes, okay. Injectable buprenorphine is a great option for select patients, right? There are some additional risks associated with the injection, right? Like I mentioned, the skin necrosis specifically. However, what I want to emphasize is with any formulation of buprenorphine, the risks are quite minimal compared to the risk of untreated opioid use disorder, which is one of the most fatal diseases out there. So yes, there are some risks associated with use, and also that is much less than untreated or undertreated opioid use disorder. Brixadi, we have a lot more dosing options with Brixadi. Sublocade, we can achieve higher serum levels. So that's all I got. I'm happy to try to answer questions, or I could just look at our pharmacists and see if they can answer some of them for me. Oh, this is just like an extra slide. One like little pro tip that I will say that I forgot to mention because I'm spacey is, in theory, you're reaching that max level, that max serum level, depending on the formulation, between 6 and 24 hours after the injection. In practice, I will say that I've had a lot of patients that really take over a month to stabilize. And so I will do the sublingual buprenorphine for sometimes several days, weeks, and maybe even a month after I start the injection, just so that they aren't having cravings and aren't using. And now I'll actually stop.
Thank you. Does anyone have any questions? I think someone put something in the chat. Lee, did you want to ask the question? Or we can just read it.
Sure. My question is that the VA population, as Dr. Carrasco mentioned, is kind of like a captive population. And from what I can tell, just a little research on the internet, some of these drugs and dosages commonly used cost about $1,800 a month. So I'm kind of curious, in maybe in your interactions with other addiction specialists outside of the VA, how laborious is it, challenging to get coverage for the drugs?
Not at all if you have Medicaid.
Right,
Medicaid is free. I would defer to other folks on the call because I don't know.
okay, thank you.
Does anybody else know? Nina? Yeah, Dr. Nina, yeah.
I don't know about that specifically, but I do know that, I mean, at least, I don't know, maybe in the last 6 months, something like that, it seems like, there was that switch. I don't know what exactly it was, like legally or, with Medicaid, but the recent change has made it a lot easier for places to get the Sublocade and be able to administer it to patients. At Trivium, we used to not really be able to do it very frequently because we had to like order the med and then we had to pay for it and they had to like get reimbursed or something. It was a big deal. And now it isn't like that. Now you order, you send in a prescription like any other medication and they'll deliver it to the clinic and Medicaid pays for it and you're able to give it to your patient. It's just similar to the other, like the long-acting injectables with the psych meds. It's been kind of a big deal, at least for us. We've been able to provide it to a lot more patients with where we weren't able to before. I just had some other questions. Alicia, thank you for the topic. It's such a good topic. And especially right now too, right? Because of that change, we are seeing it more frequently. It's becoming more accessible to people. And so it's interesting. I hadn't heard of the surgical excision thing before. And so it'd be interesting to kind of talk to others about that as well. I don't think we have enough time to talk about everything, but one thing I wanted to ask, not just you, but everybody and any other of the addiction providers who have experience with it. There's been discussion about using the long acting as sort of a good method to help patients wean off Suboxone. And I'm wondering if the other providers here have had good success with that, and if they're doing it, are you getting is there a minimum period of time that patients are stabilized on the injection before you're considering the wean?
There are so many exciting dosing things with it. So for example, and this is not directly related to your question, but I promise I will get back to it. But like if someone is going out of town and they're on 100 milligrams of Sublocade, that you can just give them a 300 milligram injection and then they don't need to come see you again for 2 months, right? So you can actually extend the dosing out for 2 months. And then once someone is on a steady state and you stop it, that you can actually have detectable levels for up to a year. 6 to 12 months. So really slow withdrawal. And I think that in the future, we are going to be using it a lot for patients to help them wean off. My personal experience is that getting patients weaned down to 2 milligrams is fine. And then it is brutal to get them off completely, right? So when they want to get off, it can be really difficult. And I think that we will start seeing more of like the lower dose Sublocade or maybe lower dose Brixadi being used for that. I have had a couple patients who have gotten off, and one I think started about 3 months ago, hasn't had any injections and has not had any withdrawal and is doing fine. So I don't have a huge amount of experience of patients that are off. I think in general, I would say, the usual, like if you've had at least 6 to 12 months and you really, really want it and there's some reason that you want to get off, like I'm willing to try. And yeah, it seems like the withdrawal is much easier, but I only have a handful of patients that have done that. So I'll defer to other folks too.
Yeah, I've had patients who are on the sublingual and come to me and say, hey, I've heard that it might be a better idea to wean off it with the injection. And so they're asking, how long do I need to stay on the injection before, I'm stable enough and there's enough serum level, there's enough depot and medication for me to start weaning. And I've been recommending it minimum 3 months, but I haven't had a patient who's actually gone through the process yet of switching to the injectable and then weaning. So.
I think the hardest thing related to that is that when I've been asked about using it to help people wean off, they are already on really low doses, and so they're looking for a helping wean off from the low doses, and we don't have an option for that. We don't have the ability to give a small amount. So the 300 milligram Sublocade dose, or the 100 milligram Sublocade dose, or the 128 milligram Brixadi dose are all meant to stabilize someone at a high dose of the buprenorphine. And so we don't have good options for giving them those lower doses. And so if we're going to use it for tapering, it really needs to be done when they're still at the higher doses. Get them on the shot for, four shots, I would say, is probably good, because you recycle back to the beginning and then stop. But we don't have the data for it, right? We don't know. But I do know that I wouldn't give a 100 milligram Sublocade shot to someone who's already tapered down to 2 and is just afraid from the taper further down from that, because it's going to be a significant boost in the dose.
Thank you. There was one more question. We have a few minutes left for the Q&A, but Brian, I know you had asked your question. I know you were going back and forth a little bit, but I don't know if you want to ask to the general.
So I'll just ask it on the screen then. I've tried a couple of times to start patients on sublingual buprenorphine directly, who have failed every other option for pain control, say with a chronic orthopedic condition. And so normally you would put them on hydrocodone, but I'm trying to put them on a safer opiate. So I want to go, say, directly into sublingual buprenorphine. A couple of times I've tried it, patients complain of very severe GI effects, cramping, pain. They get very upset at me, and so I quit trying to do it. But I figured there has to be a way to accomplish it. So what dosing route recommendation for how to start off with sublingual buprenorphine without converting from a MME 30 on hydrocodone and sliding across? How can you get on the sublingual buprenorphine directly and have it be tolerable?
Alicia, I know you were going back and forth in the chat, but do you want to start?
Oh, sure. I was just going to say, I mean, I use buprenorphine all the time. The VA and Department of Defense actually recommends using buprenorphine first line, and we are lucky that we have Butrans available, right? Open formulary, and Belbuca, which are the pain formulations of buprenorphine. And I know that not everyone has that. When I worked at Terry Riley, for example, sometimes what I would do, depending on if I could get the films, then they could cut the films into small pieces, right? And I could say take like a quarter of a film and do the 2 milligram film. That's one option. Sometimes, and then I, would dose it 2 times a day at least, maybe 3 times a day, because that'll help more with pain. Or I would, and start very slow. So start with 1 milligram or one little crumb of buprenorphine under their tongue. And I tell them, the exact dose doesn't matter, just to try to do a very small amount can be helpful. But it's just a big jump going from nothing to that, because buprenorphine is so potent. And so sometimes maybe just starting at 1 milligram for a week, or 1 crumb, 1/4 of a film for a week, like once a day. And then you could try going up to twice a day and seeing if they can tolerate it that way.
Okay. Thank you.